Acute respiratory distress syndrome, or ARDS for short, is a life-threatening condition associated with acute lung injury that results in progressive respiratory dysfunction and hypoxia. ARDS is caused by inflammatory alveolar damage and capillary endothelial injury, which ultimately leads to decreased lung compliance and pulmonary arterial vasoconstriction. Based on arterial oxygenation, patients are grouped into mild, moderate, and severe ARDS. Now, if you suspect ARDS, you should first perform an ABCDE assessment. Patients with ARDS are usually unstable, so begin acute management immediately. Stabilize the airway, breathing, and circulation, which means you will likely need to intubate the patient and place them on mechanical ventilation. Next, obtain IV access, put your patient on cardiac telemetry, and begin continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. Once you stabilize the patient, obtain a focused history and physical examination. Your patient will report progressive shortness of breath and may have a history of trauma, sepsis, pneumonia, pancreatitis, or drug toxicity. Physical exam often reveals features of hypoxia like cyanosis, tachypnea, accessory respiratory muscle use, and diffuse pulmonary crackles. In addition, pulse oximetry will reveal low oxygen saturation levels. At this point, you should suspect ARDS. Next, order an arterial blood gas, or ABG, and chest X-ray. In addition, you should estimate the fraction of oxygen in the patient's inspired air, or FiO2. FiO2 is typically 0.21 when breathing room air. For patients on supplemental oxygen, it varies depending on the mode of oxygen delivery and the amount of oxygen being delivered. Now, here's a high-yield fact. To rule out cardiac dysfunction as the cause of lung infiltrates, look for absence of jugular venous distension on examination, normal troponin or B-type natriuretic peptide levels, a normal ECG, and a normal echocardiogram. Your next step is to measure the PaO2-FiO2 ratio by dividing the patient's arterial oxygen level, or PaO2, by the estimated FiO2. For example, if a patient's ABG shows a PaO2 of 90 millimeters of mercury in their breathing room air, which has an FiO2 of 0.21, then their PaO2-FiO2 ratio is 429 millimeters of mercury. Normal PaO2-FiO2 ratio is between 400 and 500 millimeters of mercury. Next, assess whether your patient meets ARDS criteria. These include that the respiratory condition starts within a week of an inciting medical event like trauma, sepsis, pneumonia, pancreatitis, or drug toxicity. Chest X-ray showing bilateral lung opacities of non-cardiac origin, and a PaO2 to FiO2 ratio of 300 millimeters of mercury or less, measured while receiving positive end expiratory pressure or continuous positive airway pressure of at least 5 centimeters of water. If these criteria are not met, consider an alternative diagnosis. On the other hand, if ARDS criteria are met, then diagnose ARDS and assess the PaO2-FiO2 ratio. Here's a clinical pearl. Several pulmonary conditions can mimic ARDS, such as cardiogenic pulmonary edema, bilateral pneumonia, and alveolar hemorrhage. So always include these conditions in your differential diagnosis. Now, if the PaO2-FiO2 ratio is greater than 200 and less than or equal to 300 millimeters of mercury, diagnose mild ARDS. The management of mild ARDS involves treating the underlying condition. For example, if your patient has sepsis, you should immediately start appropriate antibiotics. Next, optimize ventilator management. The first step here is to set the ventilator to low tidal volumes, starting with 8 milliliters per kilogram of predicted body weight, then titrated to 6 milliliters per kilogram, with a goal of achieving low plateau pressures of 30 centimeters of water or less. These settings aim to decrease the risk of alveolar overdistension and developing ventilation-induced lung injury, or VILI. Tidal volume is the total volume of air the ventilator delivers per breath, whereas plateau pressure is the pressure applied to the small airways and alveoli by the ventilator. Next, set the PEEP, high enough to keep alveoli open, but not too high that it causes overdistension that may result in damage and VILI. The appropriate level of PEEP is usually decided at the bedside. However, lower levels of PEEP, starting at a minimum of 5 centimeters of water, are used in patients with mild ARDS and titrated to maintain maximal oxygenation. Here's a high-yield fact. Keep in mind that the more dependent lower lobes area of the lungs are affected more than the upper lobes in ARDS. So while ventilator settings may improve oxygenation in the affected areas, mechanical ventilation can cause trauma to the unaffected areas. So it's important to provide adequate oxygenation while avoiding ventilation-induced lung injury. Moreover, ventilation-induced lung injury is usually caused by overdistension of the unaffected alveoli, leading to edema, hemorrhage, hyaline formation, and alveolar collapse. You may also attempt pharmacologic management, which involves diuretics to reduce intravascular volume to help reduce pulmonary edema and improve oxygenation. And here's another clinical pearl. In ARDS, neutrophils, inactivated surfactant, and dead tissue debris fill alveolar spaces and reduce the area available for oxygen exchange. So you'll see ventilation perfusion mismatch since the alveoli still receive blood supply, but oxygen exchange is compromised. This results in hypoxia that does not improve with increased FiO2. Finally, there's general ICU supportive care, which includes enteral feeding, DVT prophylaxis, and GI ulcer prevention. Care bundles, a set of evidence-based practices commonly used for ICU patients, are used to reduce nosocomial infections, which is very common in ARDS patients. A ventilator bundle includes practices like daily oral care with chlorhexidine and raising the head of the bed between 30 to 45 degrees, all practices to prevent ventilator-acquired pneumonia. If your patient has a central line, be sure they have a central line bundle to prevent central line-associated bloodstream infections, which includes antiseptic dressing changes, daily assessment of the need for ongoing central line access, and removal of the catheter as soon as it's no longer needed. Now, let's go back and take a look at individuals who have a PaO2-FiO2 ratio greater than 100 but less than or equal to 200 millimeters of mercury. In this case, diagnose moderate ARDS. Management will include the same therapy as for mild ARDS, and you may add higher PEEP levels to improve hypoxemia. You may also consider prone positioning, which is accomplished by placing the patient face down on their abdomen for at least 8 hours a day. This adjustment may improve ventilation in the unaffected areas of the lung, leading to reduced intrapulmonary shunting, improvement in oxygen exchange, and prevention of VILI. Finally, if the PaO2-FiO2 ratio is 100 millimeters of mercury or less, diagnose severe ARDS and treat the patient as you would for moderate ARDS. In addition, consider neuromuscular agents to induce paralysis, improving pulmonary compliance and ventilation. Finally, you should consider extracorporeal membrane oxygenation, or ECMO, in patients with severe refractory ARDS. ECMO is performed by pumping blood from the body to a heart-lung machine, where a special membrane oxygenates the blood and removes carbon dioxide. Then, the blood is warmed before returning the blood to the circulation. In the setting of severe ARDS, this may be the only effective way to maintain oxygen saturation. All right, as a quick recap, if you suspect acute respiratory distress syndrome, order ABG, chest X-ray, and calculate the PaO2-FiO2 ratio. Next, use ARDS criteria to rule out or confirm the diagnosis. Once you confirm the diagnosis, assess the PaO2-FiO2 ratio in order to guide your management, which primarily relies on treating the underlying cause and optimizing ventilator management. Additional treatment options to keep in mind include diuretic use and general ICU supportive care, such as enteral feeding, DVT and GI ulcer prophylaxis, and care bundles. Finally, consider higher levels of PEEP, prone positioning, and use the neuromuscular agents and ECMO based on severity.